in the name of your organization next to your name. Like, for example, what I do is I click the three little buttons there, the three next to mute, and I go to rename, and then I put my name and my organization, and then that way we know who is who. So we have Veronique Dupont from the RHSC. We have Emma Burgess from CHI. We have Annette from Project COF. Leanne from Mama Pinkin. Thank you, Leanne, for being here. We have somebody called admin. I don't think anybody's called admin.
Hello, everyone. My name is John Muyaya. My organization is ACDCS. I am in Kinshasa,
In
DR.
Kinshasa. Soyez le bienvenue.
Yes.
Why don't you put your name and ACDCS so we all know who you are? Okay. Like Fabrice. Idris, we're missing the name of your organization. Sada, also, we're missing the name of your organization. You just click on the three dots and you put rename and you can add the name of the organization. All right. Okay, thank you, Laura. All yours.
Okay, thank you everyone for joining our community of practice for the Catalytic Opportunity Fund for New and Lesser Used Medicines for the prevention of postpartum hemorrhage. It's great to see everybody. This is a platform for all of you to come together and share progress, updates, successes, and challenges from your projects, and to connect with other grantees and to learn from each other. And we do have 10 organizations present, and we have 90 minutes. So it's going to be very swift updates because we also want to leave time for discussion and questions for you to ask each other. But for now, why don't we go ahead and hear from each of you. I will go through the list of our grantees and call on each organization to have one person speak and give some quick updates, and then answer any questions, and we can see how far we get in our 90 minutes. Leanne, I did receive your request to speak first because I know you have another meeting to attend. If you'd like to come off mute, I will give you the floor.
Hello, thank you so much for that, Laura. I appreciate you obliging my request last minute. It's actually World Menopause, not menopause, World Menstrual Hygiene Day. And so I'm at an event for that. And so there's like some young girls I have to go talk to in a minute. They're waiting for me. So yes, Leanne Riss, Mama Pekin Foundation. I also want to recognize Mamadou Cissé, who's also from Mama Pekin Foundation on the call. And we are happy to report that we have gone very far in the rollouts of the rollout training of our Sierra Leone, and we have completed we have trained 9 districts successfully out of 16 districts. And we have also recently partnered with Project Hope, who's also on the call. Also want to recognize them. With the last few trainings, we'll be partnering them hopefully with a few trainings in the future to complete the entire district. Our main challenges, again, haven't really changed much. It's really about distribution of the commodities, the medicine. The medicine is in country, it's been here, it's just about getting it to the last mile. This has been the struggle. Also working with the districts on the district level team to make sure that they understand how it should be distributed based off of, you know, number of deliveries. Like, because I think they really just don't understand based off of, you know, women of reproductive age, all of the data that they collect. how do they know how much they're supposed to get? So I think that's been the struggle. We've really tried to support, sorry, so noisy, as much as possible with this, but it has been a struggle. Fortunately, I will just say, is the last two districts that we have trained, which is Cambia and Bond districts, we were able to successfully distribute medication simultaneously with the training, which really helped a lot, right? So we reached out to the DHMT prior to the training, talked to them and said, we know that you have it at the district stores. So along with the training, as soon as the training is over, when we are having people leave, we are giving and making them sign for their portion of the medication, right? And so we've also helped them with that. So that has been very helpful. I don't know if it would happen as a standard everywhere, but those two districts, yes. So that's really the update for now.
And Leanne, you have also successfully been able to leverage some funding from Fairing to continue working. I understand that. Maybe you can explain a little of that experience to your colleagues so they know how they could continue working in the future.
Yes, thank you for that. Yes, we were able to also secure a small amount of funding to so we had the first batch of funding that was 16 districts in Sierra Leone. We completed the 8 and then the funding ended. And then now we were in search of, funding to complete the balance, the remaining 8. And we were so fortunate along with the help and of course the guidance of the Ministry of Health, our Director of Reproductive Health, Dr. Francis Moses. We had a meeting with Fairing. Fairing was reaching out and wanted to know what was going on with what's the status update on the medications. And he also let them know that we are in the process of doing this rollout training and weren't able to complete all of the districts. So they stepped in and they rewarded us with a grant for 4 districts. So we're currently doing those 4, which means we have a remaining 4 left. And we hope to partner with Project Hope in trying to get the rest of that done. So we're working that out. We're working the details out, but it's been great because at least we have the 4. So we've started the 4. 1 out of the 4 we have done so far. So we're on the ball is rolling. It's rolling.
Thank you so much for sharing all of your project successes and challenges. It's always interesting to hear how things have progressed and great to hear that you've followed on and found additional funding to roll out to additional districts. So thank you so much. Since you're working closely with Project Hope, how about we talk to them next? Who's speaking for Project Hope?
Okay, hi. So I'll be speaking for Project Hope. Annette.
Thank you.
Yeah, thank you. So yes, for us, we started our grant March 31st, 2025, and we've been in the process of really finalizing and ensuring that our scope of work is in line with the ministry's requirements and priorities at this time. So we have 4 major activities that we are pursuing. One is, of course, to support the technical working groups to ensure that TXA and HSC is part of the discussion across board, and also to ensure sustainability in terms of availability of commodity. The second activity, which Leah had already mentioned for Mama Pikin, is to support with the remaining 4. So when we looked at the budget, we found out that we could support 2 out of the remaining 4. So we still have 2 left, but we'll be supporting 2 of those districts. So that's Loco and Pujol. So we'll be supporting those districts in collaboration with, of course, Mapikin and the Ministry of Health. Beyond that, we're also looking at post-training supportive supervision. So you've done the training. How are we ensuring that at the facility level, these commodities are actually being used? So that's part of the activities that we'll be supporting, working, of course, in collaboration with the Ministry of Health and Mama Pikin for that activity. So that's for activity 2. For activity 3, because we also have a good relationship with the pre-service training, so the schools of midwifery, the schools of midwifery and nursing in the country. We're also working with, the different schools in Freetown and in other districts, because what we are looking for is sustainability. So once we're able to introduce this HSC-TXA training from the schools, it's cheaper in the long run. You don't have to always pull out people to go and train. So from the school level, they already have the information. So we've done the first batch of training. We still have additional schools that we're going to be working with the ministry to conduct. And the last activity for us, of course, is the data system. Right now, in our national DHRS2, we do not report on HSC and TXA. So it's not officially documented anywhere. So we're also following up with the Ministry of Health to ensure that the new data collection tools are rolled out. We'll also be supporting with printing some of these tools and ensure that they are distributed to the facility. So beyond these four broad topics, I know, like Leah mentioned, we have a lot of issue with last mile distribution. So we are also leveraging our relationship with other implementing partners in Sierra Leone to see how can we do an integrated supply last mile distribution with other commodities. For example, the Global Fund commodities. How can we ensure that when those commodities are going out to the facilities, we are also incorporating MNCH commodities, across board. So those are like our own activities and a summary of what we're doing. Thank you.
Thank you, Annette. Yeah, I should have mentioned that, every organization is at a different point in the implementation of their project, and Project Hope is one of our newer grantees who is just getting started. And so, kind of doing those introductory activities, still working with the Ministry of Health to get the work plan finalized and in conjunction with Mama Pinkin Foundation. So it's great to hear that, yeah, you've already started with the pre-service training and are making progress there. Does anyone have any immediate questions for Project Hope or Mama Pinkin Foundation from Sierra Leone?
I just have a comment, Laura.
Sure.
I raised my hand. Just to mention that Project Hope, it's probably one of they're the only ones working in pre-service training. And frankly, it's one of the most sustainable activities you can have, because when professionals receive this kind of training before they start their clinical service, it is key. It lasts forever. And as Annette was saying, it is an excellent investment. So in the future, if there is a possibility of including pre-service training, going to the universities and the colleges, training future doctors and midwives in the use of these life-saving medicines, it does pay. For every dollar invested, it does pay a lot of returns. So I would encourage all of you to consider working in pre-service training with your colleges and universities. Just that. Thank you.
Thanks, Milka. Okay, why don't we go ahead and keep moving along? We do have a couple other newer COF grantees to this call who were not on our first one held in December. So I would like to invite ACDCS to take the microphone.
Yes, thank you, Laura. My name is Fabrice from DRC. So ACDS stands for Community Action for Development and Social Cohesion. Is a national organization under Congolese law based in Kinshasa, which is present in 7 regions of the country since 2016. So ECDCS continued to contribute to promote to the promotion of human dignity through multi-sectoral actions, placing health at the center of everything. So the DRC currently facing numerous challenges, such as limited access to healthcare, epidemics, and climate issues and conflict. So our contribution to the reduction of maternal mortality related to postpartum hemorrhage in the DRC. So that is our project. So since 2023, ICDC is in collaboration with UNFPA and the Ministry of Health has expressed the need to contribute to saving women's lives through proactive action. Our project, which is the strategic initiative for the implementation of care and services for prevention of PPH, aim to significantly reduce maternal mortality and morbidity due to PPH in the Kwango region. The project is set to drive a major transformation by linking implementation and learning with demand generation effort, showcasing the feasibility, accessibility, and assure quality of istabocarbetocin across 14 health districts in the Kwango. So I will start by talking about a little bit about our strategy used by the project in Kwango. As a catalytic initiative, ICDC aims for all implementation approach derived from the strategy to be included in the National Reproductive Health Plan, thereby facilitating an adapted and participatory scaling up of the process of introduction of the istabocarbetocin in the country. To achieve this, the road is still long, but since the beginning of our project in April, we have carried out the following activities. Let me begin by saying number one is to create a enabling and comprehensive internal and external environment. We organize an orientation for all project staff. We developed also a leaflet detailing the project and our area of intervention. We held a project kickoff meetings at the Kwango region, a census meeting on the implementation strategy, and we also, in collaboration with the head of the Provincial Health Division, civil society organization, and healthcare providers, conduct a mapping of stakeholders who could be directly or indirectly involved in the project implementation. And to finalize this part, an initial project assessment was carried out to establish a baseline. So this assessment allows us to create our own dashboard, including the project key indicators as well as other information related to the sexual and reproductive health and drug management. So at the national level, we held the official project launch with which was rich and productive day under the leadership of the General Secretary of the Ministry of Health and other stakeholders, health cluster, and civil society organizations. So with the expert of the Ministry of Health and the professional society, a workshop to review the tools was organized, and teams are currently in the field to start the cascade of training session, where we expect to have 644 providers. The cascade training will continue until June Okay, to conclude this point, community radio have already begun awareness campaign on BPH prevention, informing the public about the value of antenatal care and the availability of medicine. So indeed, the support of the UNFPA, we had already stocked over 19,000 doses of step carbetocin in Kwango. And we hope by June, we will already have the first data regarding the implementation of the project. So some challenges, as you know, the huge size of the Kwango region, which has a direct impact on the accessibility to some districts. But to meet this challenge, we decided to create a WhatsApp group according to the area and level of importance. For example, a WhatsApp group for providers, for data managers, for drug managers, as well at the central level. And we have also joined the National Reproductive Technical Working Group to share our efforts and learn about the opportunity and the contribution of other partners. Another challenge is the quantity of stable carbetocin dose provided by the UNFPA for 2025. As I said, it's about 90,000 doses. So we have worked on an adapted deployment plan to help us to avoid stockout until the next supply chain, because the next supply will come on 2026. So to conclude, I want to share with the group one strategic success. On this month, thanks to the advocacy effort, ACDC has just financed and facilitated a workshop to review the introduction and scale-up plan to stable carbetocin, tranexamic acid, and folic acid 5 milligram in the DRC. This plan will extend until 2013. This effort was funded by Fairing. We are currently advocating for this plan to be quickly approved by the Ministry of Health so that it can be widely disseminated across the country. I would like to end my request for your WhatsApp number in order to share with you some updates or plan or other information related to our effort in the DRC. Thank you very much.
Thank you, Fabrice. That's an excellent update. I had a question regarding the doses of heat-stable carbetocin. I'm wondering if you were experiencing similar challenges like Mama Pinkin mentioned about reaching last-mile facilities, or if the doses are already at the facilities, or are they in a central medical store at the moment? Have you had any challenges with the distribution?
No, the doses are on the health facility now, but the quantity is still, I can say it's 50% of our needs.
Okay. Excellent. Good to know. Thank you. Does anyone else have a question for Fabrice and ACDCS in the DRC?
You said that was 50% of your need?
Yeah, yes, because I was around 3,000, yes, 300,000 doses, but the UNFPA gives us only 1,900 doses, 19,000 doses, please.
Remember that this is your community of practice. This is the time to ask questions, to report any challenges. So don't be shy. Don't be shy. We're among colleagues here. So don't be shy. I encourage all of you to ask and make comments. Who's the next person?
We'll go over to LifeNet in Ghana to hear their progress so far. They started in January, I believe.
Hey, Laura. My name is Idris Boabe. I serve as the country director for LifeNet in Ghana. And I'm in this room with my colleagues for monitoring and evaluation and the project officer. LifeNet, because we are new, pardon me to spend 1 minute to tell you about ourselves, then I will go into the project. We are a faith-based health system strengthening organization. And we work in Africa in about 6 countries. Prior to this project, our work in Ghana had focused on building the capacity of health workers in faith-based health institutions to be able to deliver clinical services excellently. And also for the people involved in managing the health facilities, we are speaking about administrators, accountants, and other people to manage the facilities in a sustainable manner. So we have, in addition to our clinical trainings, been doing trainings in financial management, health facility planning, inventory management, etc. So that had been our preoccupation in the past. We received the support from the Catalytic Opportunity Fund for January this year. And just about the same time, we had several blessings together. Also, Ferrin supported, and we were able to raise funding from a private foundation that came into the commodity purchasing side. So I'll be speaking about all of those ones briefly. Right now, for this project, we are working with 55 health facilities spread across 10 out of the 16 regions in this country. So we work from the north of the country, close to the Burkina Faso border, down to the coast in Accra. 3 things we are doing with the health facilities. First, we did a baseline study. Second, we have done series of capacity building. And then now we are in the commodity supply and mentoring phase of the project. So in our baseline study, I'm just excited to share a few of our findings. 35% of the staff interviewed had heard about heat-stable carbetocin as a drug that exists somewhere, but 0% had ever seen or used heat-stable carbetocin in all the facilities. 5% had used a drip before. Drip is the article used for quantitative measure of blood after delivery. Only 5% had ever used drip. So to the large extent, midwives were using visual judgments to tell if a particular delivery was PPH or not. And that is how it was. Okay. For the training, we focused on the entire emotive bundle. Emotive, we went through the entire phase, but we focused more on using heat-stable carbetocin because that is the name of our project, Enhanced Postpartum Hemorrhage Prevention using heat-stable carbetocin and drips. So through the emotive phase, we focused more on using heat-stable carbetocin to prevent postpartum hemorrhage in the first place, but yet still went ahead and taught all that is required in case there is postpartum hemorrhage and how to use the emotive strategy in preventing the postpartum hemorrhage. We did that to selected 83 midwives. We call them the midwife champions. And they were all responsible for going back to their zones and cascading these trainings to other health personnel. So as we speak from March, we have 253 others that have been trained. But there are over 1,000 personnel in our portfolio. So there is still work to be done in that direction. But this is from March to May as we speak. The trainings did not only involve the clinicians, it also involved the pharmacists, and those who were in charge of procurement of medicines. We work in the non-governmental space. And so all the facilities, health facilities under us, have the free will to procure their own medicines. Some of them have pooled procurement systems already existing, like the Catholic Health Service of Ghana, but others do not have the pooled procurement system. So for this current training, we are looking at inventory management, quantification of medication supply, estimating your usage and all of that, and also linking the facilities to AXMED, which is an excellent digital platform for ordering and receiving of medicines. So that is ongoing. I'm saying ongoing because even today, the last group of health administrators and procurement people are in training right now. They will finish tonight. So that is work ongoing in that direction. So all the procurement officers and managers involved in these 10 regions are receiving this capacity training and being linked to the AXMED platform, in addition to other ways of getting commodities. Now, prior to starting this project, with the support of another founder, we were able to procure 19,000 drips. Our annual delivery numbers is about 17,000. And so we have enough drips to cover the entire year's delivery. That is being given to the health facilities right now, and they've started using them. The funding allowed us to procure, using AXMED, about 3,850 doses of heat-stable carbetocin. That is scheduled to arrive in June. So now the demand is being created, and we are eagerly expecting the heat-stable carbetocin in country. It will cover, looking at our annual delivery, this is only going to cover slightly about a quarter of the delivery. And so we are looking for the next phase of funding to be able to request for more. However, the health facilities have all been given the ability to be able to use the AXMED platform to order for the next dosage of heat-stable carbetocin. And the quarter supply is to be able to give them the lead time in their respective orders. Right now, after this training, our next steps would be a series of mentorship, which we have started already, but a lot of mentoring. Our LifeNet model, after training, assigns a health personnel to be accompanying a group of health facilities. So one person to about 12 facilities. We call that mentoring. Regular visits, regular participation in the work they do, and direct observation of what is the changes happening. We would also be collecting data because we want to be able to write our experience and publish scientifically from the work we are doing. We are looking at a cost effectiveness analysis study that can happen from all the work that we are doing so far. So those are our next steps in this country. Thank you. I'll be very happy to answer questions.
There is a question in the chat regarding the supply and use of TXA in Ghana, asking what the quality is. How good is the supply and use of TXA?
Most of the health facilities we are working with already know and use tranexamic acid. So this project focused on the newer and unknown ones, which is heat-stable carbetocin. And there was a study that really showed that the oxytocin available was about 70% non-drug, was just something else. So all our focus right now is on what they do not know, but they already use tranexamic acid, the largest thing.
Thank you. I see Fabrice has his hand up. Please go ahead.
Yes, thank you. Yeah, Idris, just a quick question is about the supply chain mechanism or approach. What approach do you use? Is push or pull because of to to avoid those difficulties.
Okay, Fabrice, I did not hear you fully, but what I got from your answer is the approach to the supply chain. So we work in a private space, though in Ghana, the faith base has a good interaction with the government, but there is also the option to do our own procurement. So the introduction of AXMED is a very important central support to medications purchase. Right now, the project through the trainings is creating a lot of demand. So the demand creation side is more or less sorted out. Then there is making the process for forecasting and ordering of medication easy for these facilities through the AXMED platform. So we are working from both angles. I hope I answered the question. Thank you, Fabrice. I'm seeing a hand from Okechukwu. I don't know if it's for us or for, it was on earlier.
Yeah, thanks, Idris. So my question is around, you did mention like you plan to conduct a cost effectiveness analysis, right?
Yes.
Yeah, so could you like say more on that, especially around what are you comparing against in terms of PPH management? What are the interventions you are comparing against? What are the intended outcomes you are going to look at? And then have you also thought about challenge how you're going to collect your cost data, right? And all this, yeah.
Thank you, Okechukwu. The CEA is related to the heat-stable carbetocin versus oxytocin. So the facilities are used traditionally to oxytocin, and there are various parameters, the cold chain that is kept or unkept, transportation from the various quarters there. So that is what we are matching, comparing with the heat-stable carbetocin, which is coming to us at an access price from what we got from the AXMED platform. We haven't cleared the drug yet from the port, and this is being done by one of the FBO partners. It hasn't been cleared from the port yet, so we do not have the final estimates, but the source cost was $0.84 per vial at the source. We are anticipating a few more costs to come from the clearance at the port, etc. We are already working with FBA, obtaining the necessary documentation for clearance. So all of that is being done. Our hope is that we should be able to land it somewhere around $1.5 at the health facility, possibly to the mother. So all of this is what is going to go into the study, and we should be able to speak with evidence close to the end of the year. I hope I've answered the question, Okechukwu.
Thank you for providing more detail about the cost effectiveness study. We have another question in the chat for you about oxytocin. Would you be able to repeat what you mentioned about 70% of oxytocin? Was it the medicine that, oh, go ahead.
That's a local FDA study, Food and Drugs Authority study that was done about 2-3 years ago in Ghana with support from the USAID. So that information exists in literature. If you would like me to share a link or something, I could work at that and get it to you.
Thank you.
That would be great. Thanks so much, Idris.
Thank you so much for sharing all of your updates, Idris and LifeNet. It was great to hear your progress.
Thank you.
I think we'll continue on, and I'm looking to see if anyone is here from Selena Center in Nigeria. I'm scrolling through all the names. Not seeing.
I don't see Selena.
Okay. Maybe they will join at the hour. We can come back to them. We do have a couple of grantees in Kenya, and I know Polycarp is here from ICRHK. If you would like to share your updates and challenges, we'd like to hear from you.
Thank you. Thank you so much, Laura, Milka, and the team. It's always a pleasure to join this team. So I'll share a bit of our updates for where we are as ICRHK. So far within the 7 counties that we are supporting in this program, we've been able to move into 4 out of the 7. And we are hopefully engaging the rest to see by the time we are supposed to sort of close out, we should have met our objectives for that. We are also working together with the counties to support them to sort of order and the heat-stable carbetocin doses from KEMSA. We realized when we were doing our facility readiness assessment, majority of these counties were not aware that this commodity was already procured in the country. And so part of our role, even as we move into the different counties, is to alert them that this commodity is lying there in KEMSA. You can start making the orders and start using it. I'll just give a bit of statistics. So far, we have 45 out of 47 counties in the country that have already ordered this commodity from KEMSA. KEMSA last year, I think in July, ordered about 360,000, procured 360,000 doses of heat-stable carbetocin to support the country. And out of that, as at Friday last week, about 196,000 doses have already been issued, not to the counties, but to the facilities. And they're already reaching the, or rather being used to the clients. So for our counties that we are supporting, 7 counties, about we have contributed about 25% from the total amount of doses that have been issued. So in our 7 counties we are supporting, they've been able to order about 46,190 doses, which are spread across different facilities. Majority of those facilities are the ones that we are sort of working into, or rather implementing this project, and we hope to scale that up, to scale the use and rather for them to continue ordering from that. One of the good news from the advocacy that we've been doing around the country is that KEMSA also sort of procured an additional dose of about 160,000 to sort of, supplement the initial procurement. And that is a big win for us as a country. It means that we are sort of assured of continuity in terms of the heat-stable carbetocin. However, we still have challenges here and there. Even as we move on, there is still need to create more awareness to the healthcare providers on the eligibility of using heat-stable carbetocin. As we move around, as we interact with them, as we discuss, as we continue with the mentorship, we realize that some of these drugs are kept because they are being used only to high-risk clients. Number 2, they are used during certain hours, not full, maybe at night or over the weekends when they believe probably they may not get help. The comments, or rather the feedback we are getting for heat-stable carbetocin is very good, because the healthcare providers who are administering the drug, they call it wonder drug within the counties we've been able to visit. And that's why I think they also positively, when you look at it, they've sort of preserved it for the high-risk clients to PPH, because they believe once you administer this drug, then the chances of getting a PPH becomes very minimal. And so we are just encouraging them that whether this client is high risk or not, all clients should be able to benefit from the heat-stable carbetocin. And will be interesting maybe towards the end, or rather maybe when we'll be having our next session here, we'll actually share with you what has been the uptake like for the 46,000 doses, how many have actually reached the intended clients. It's a data that we are compiling, and we hope that we shall be able to share with you when we meet, probably within the next caucus meeting. The other success that we are looking at here is a lot of private facilities that were not we didn't plan to go there and train, though we had a mix of both private, public, faith-based organizations, but there are those private facilities that came to us requesting that if we can go and sort of just support them, mentor them, offer this kind of training to them. And so ICRHK sort of did that, within its own cost to just go beyond what was pre-intended. And even for those facilities that I can say, because we are supporting 15 facilities per county, you find those facilities that are attached or within the catchment population of those that we are supporting, they've come to us to request, why can't we, even just have a webinar, even just go for a day and support them. So there's a very good reception of this program, and a lot of people are wishing if we will go beyond and sort of try to meet them, because the main facilities we are working with, the level 5 and 6, they no longer receive the kind of referrals they used to get from complications arising from PPH. And that is one of the good thing and the good story that I received and the team is always getting. So they are actually their thinking is, why can't we focus on the level 2s, the level 3s, so that we stop those mothers complicating the morbidities out there and the mortalities. So a lot of good feedback from the frontline health workers who are actually administering these commodities. And when I was in one of our county in Kilifi, the health workers were saying, even mothers who know that this facility is actually administering, they've had that drug, we call it Kausha in Kenya. I think my Eunice will come in next and share more, because it dries. Kausha is sort of drying, so it dries all the blood. So you find women preferring to go to deliver at a certain facility that is actually, is implementing or rather administering heat-stable carbetocin for that. So a lot of good things, both at the facility and at the community level, in terms of the feedback from this commodity. We've also tried our best as ICRHK to include students who are doing their rotations within the facilities. So our approach is very accommodative. We have the OBGYNs, we have the medical officers, we have the pharmacists, we have the nurses, we have the midwives, and we don't forget, every time we go, we ask the facility to give us the students who are on rotation within that unit at that time, for purposes of them also sharing with the other teams and even for learning purposes. The next step that we are working on as ICRHK is to ensure, currently the country is working on a WENE acceleration plan, the Every Woman, Every Newborn, Everywhere, the National Acceleration Plan. And we are working very closely. We've given our inputs to the technical team that is working on the document that will be launched by the Ministry of Health, that heat-stable carbetocin be a priority in terms of what will be highlighted in the document. So as we accelerate to ensure that we meet the SDG targets by 2030, heat-stable carbetocin should also feature prominently. And I'm glad that it has been taken well. And when that document will be launched, we'll be seeing HSC prominently featuring and the president sort of talking about it on why it is very important, and will probably give out some data on why we feel it should be scaled and it should come out there so that all facilities may be able to benefit from this drug. So for us as ICRHK, I think I can say we have a lot of more positives as opposed to challenges. The only challenges we're having is financial, because we will have really wished to go out strongly and reach other facilities, or even saturate, so that more women, more communities can be able to benefit from these commodities. But we are working together with Kenya Medical Supplies Authority, that is KEMSA, and also other government agencies such as the KMTCs, the Kenya Medical Training College, to see that even as they review their curriculum, they can factor in some of these components of heat stable carbetocin within that, because they are actually within the circle. They're actually working on reviewing their curriculum for the nurses and the midwives currently. So those are some of the updates. And back to you, Laura and Milka. Thank you.
Milka, is your hand up? Oh, we have a couple other hands up. I saw Mimi's hand first in the chat, so go ahead.
Okay, good morning. I didn't even present myself at the beginning because I was a little bit late. My name is Mimi Mirror. I live here in the United States in Charlotte, North Carolina. I'm a ACDCS member. So I have a question. I don't know even Polycarp can answer my question. I would like to know how the community do the engagement. So how the engagement is done to create the demand, because this is a very huge and is very important topic while you are doing a sustainability. So I would like just to know how the community proceeds about it.
Laura, should I respond to that first?
Yes, go ahead.
Thank you. So I think I'll start it off and give to my colleague, Peter Mutanda, who is here also to give, because we are working very close. So one of the way we are sort of engaging the community and creating demand is, one, we are using the social accountability sessions between the facilities and the communities. So we have the community dialogues, and you realize in our level that we've really concentrated on, because our aim was the last should be the first. Those who are the last mile should be considered first, because our concentration has always been within the bigger facilities. But for us, we thought of going out there to those facilities that are conducting deliveries, but have sort of been, what can I say, they're not given the much attention they should be. So we are working within those facilities. They've been attached with the community health promoters, who are able to, continue sensitizing these women, talk about the danger signs, talk about, the quality of services that are being offered to these facilities. So ours is, the sensitization bit is to ensure that these women come to the facilities, for delivery and other clinical purposes, so that we rather prevent home-based delivery. I don't know, Peter, you have something to add?
The explanation
you can go ahead. Yes.
I think the explanation is really, really good, and I really like the approach, because for me, that is it was the main I was asking about. I was trying to figure out how that can be done, and thank you so much. You really give me the great and awesome answer. Thank you.
Thank you for your question. Hadija, did you have a question?
Yes, Laura, thank you so much. Laura, kindly confirm you can hear me.
Yes, we can hear you.
Okay. Polycarp, thank you so much for the very insightful updates. I think for me, my question may not necessarily go to Polycarp, but it's for all of us just to reflect. So we all know that apparently the heat stable capital that we are using is on access price, but we are equally getting entities that are for private, not for profit, who equally supply private facilities, because I noticed in Polycarp's his submission, he was saying that there is interest that is coming from the private sector. And we know that access price is different from the commercial price that the private facilities are supposed to access the heat stable capital. So for me, I just want to understand from colleagues here, how are they going to be able to regulate to make sure that the heat stable capitals in that facilities are supposed to access for access price do not go and maybe cross over to the private facilities? Is something like that, Laura? I just want to learn, because for us, I think we are already getting a little bit of challenge, since some private facilities do get the commodity from the private not-for-profit facilities, and also the health workers. Some of them work in private facilities, and some of them also work in the private not-for-private facilities. Over to you.
Maybe I can start it off from our experience with in Kenya. So one of the things, Kenya is actually implementing a strategy called the Total Market Approach, TMA, but it has been majorly within the family planning commodities, where it's a strategy that ensures that what the private and the public service providers, distributors, and manufacturers, they're able to harmonize their costings in different health, maternal and newborn commodities that are being offered. So it's really, like you said, it's really a point that we've really been thinking and reflecting a lot on how best can we approach this, this setup. One of the areas is that majority of the private facilities in Kenya, they've been issued with a government number, which is called the Master Facility Code, the MFL number. So this code allows them to benefit from some of the government, what can I say, things that government, or rather the Ministry of Health issues. Like they're able to get registers, the normal registers from Hemorrhage. They're able also to get vaccines within the normal cold chain, so that it protects them from, buying or rather procuring at very high prices, as opposed to the normal rates that have been regularized by the government. And so it is the same for us here. So they are also encouraged to order using their master facility number from KEMSA. So they can still get these commodities from KEMSA, because the government, or the Ministry of Health rather, has issued them with a unique code, allowing them to also benefit from what the other public facilities, also get as a benefit. I think that is one experience that we have in Kenya.
Thank you, Polycarp. I do see Momodou has his hand up, and then we'll go to Fabrice.
Okay, thank you for the question, and thank you, Polycarp, to share the Uganda experience. I think I will go quickly for the DRC experience. First of all, the government, by the Ministry of Health, of Public Health, pay a percentage for drug purchase. This is the first way. And secondly, we organize a national technical working group, which include financial and donors partners, such as UNFPA, such as other partner WHO, and civil society organization. And we include the chief of the region, health region, and to discuss about the need, the country need. For example, before to purchase for medicine, the country organized a national quantification of all maternal and newborn drugs. And after that, government pay a percentage to get the medicine on a reasonable price. That is the experience of my countries. So, for example, currently we purchase for 2 million of carbetocin doses for 2026 to 2028, and the government already pay this percentage. Now we are waiting for the supply of that quantity. Yeah.
Thank you for sharing the DRC experience. One more do from Mama Pinkin Foundation. Did you want to speak up quickly?
Yes, please. Thank you so much, Laura. Maybe this question is for both Fabrice and Polycarp. So I want to know if you guys had a preset criteria prior to the distribution of the drugs to the counties, because we know the health facilities are not of deliveries happening in those facilities, are able to set your preset criteria, for the distribution of the drugs. Thank you.
Were you able to get that, Polycarp or Fabrice, about the distribution of, was there criteria or preset criteria for distribution to facilities?
Thank you. There was the country developed a quantification plan for, it's a national quantification plan that factored in all the health facilities in Kenya, and rather the need depending on the deliveries across the country. And so when these drugs came into the country, I think for Kenya, I can say there was no barrier for any facility, because it was already agreed that from level 2 to level 6, they can actually administer this drug. So all facilities were given the option, or rather the opportunity, to go ahead. As long as you conduct the delivery, you can go ahead and order these drugs from KEMSA, and they'll deliver to your doorstep. The only barrier we had, or rather the challenge, that most of these facilities, especially the lower level and those within the interior, were not aware that there was this commodity. Some of them have heard about HSC, but have never interacted with it in bid, but there was no criteria. However, we are currently advocating, especially for the facilities with very, high volume facilities and the health centers, that they order these according to their workload, especially the monthly or rather the annual workload, so that we ensure that all women receive this commodity. So for Kenya, it was open for all the facilities, as long as they met the criteria from level 2 all the way up, they can order for this commodity.
Thank you so much, Polycarp, for all of your insights and experience for all these questions. I recognize that we still have several more organizations to hear from, but I don't want to, I do like the dialogue and the questions that are coming up, so I don't want to cut those off at any point. But if we could just quickly hear from the remaining organizations, we have Midwives Association of Kenya. If you can give a brief update.
Thank you so much, Laura and the team, and good evening, and apologies for joining in a bit late when others had already begun. However, I have at least positive feedback to give this time. Last time when I presented, we had a lot of challenges, but then for now, at least we have a breakthrough and we are continuing. So what we are doing as Midwives Association of Kenya, we initially applied to disseminate emotive guideline through trainings, and we wanted to do it in 7 counties initially. However, the Ministry of Health had plans, and they said we cannot only focus on postpartum hemorrhage, but rather we need to do a whole EMONC training. And the EMONC training that the country does is 5 days training, which is quite intense on all emergencies, most of the emergencies for obstetrics and neonates. So hence we had to reduce to 3 counties. Yes, we had to reduce to 3 counties because we couldn't manage all the counties given now the magnitude of the resources that was required for training of EMONC. So far we have achieved meeting the county teams for all the 3 counties, that is Machakos and Murang'a and Busia counties. So we have done country entry meetings successfully in all the 3 counties. And we have also done training for mentors. So we wanted to do trainings for TOTs nationally, but now because the country has some teams or a team of experts that have already done TOT training. So we now are doing mentor training for the counties. So far, we've done mentor training for Machakos County and Murang'a County. Initially, we wanted to do 15 per county, but then you go in and you find an extra person brought on board. Maybe the reproductive health coordinator feels they want an update. So eventually we ended up doing 17 for Machakos and then 15 for Murang'a. So one of the requirements that we needed to do for all the counties was we had to have the initial standardization of EMONC training for everyone before we choose the mentors from them. So we had a challenge in one of the counties, that is Busia County, because in Busia, they've never had EMONC training for the last 10 years. So therefore, we have to do initial standardization of about 30 people. Then we pick from there the 15 mentors that we have to train, who will eventually go to the facility training. So because that wasn't part of the budget, and as I've already mentioned, it's quite intense, we had to collaborate. So together with the Ministry of Health and Chai, so Chai was able to, is going to support us for training of 15 mentors within Busia County, and on condition that we also support the neighboring county, which is Bungoma, which wasn't part of the project. We do 15. So the mentors from Bungoma will have to come and join Busia team for us to be able to train 30, a class of 30, which we thought is okay. But then we have insisted that the county gives us members who are actually in the facility, who are working in the facility, who are able to take up the mentorship, the training, and be able to progress to mentorship course. Then they go and cascade it down to the facilities. So far we are happy, at least with the collaboration with the Chai, because that will be able to support us with that one class. The other achievement we found is many people asking for this same training. So of course, funding will be a challenge, but then I've liked when Martha has indicated that a pre-service training needs to be reinforced, because MTCs are actually asking. We had planned to be training within the medical training colleges initially to reduce on the cost, but unfortunately they are in session, and therefore the facilities are not available within the colleges to be able to do the training. But however, all the counties we've gone into, the medical training colleges are asking, we want our faculty members to be trained so that they can be able to teach the students before they leave the pre-service session. So I think that's one of the areas that we are looking at, maybe if we ever find some more funding to look into that. The other thing, positive thing that we've had is someone has actually approached us to provide technical expertise as well for training of EMONC training, and that is World Health Organization. They said someone recommended from MSD for mothers. So I think we are now negotiating. We are still at talking level to know what would be our role and what would be their role in all these, especially in the training. And I think the other positive thing is we've had very good relationship and discussions with the ministry and also the county teams to ensure there is success. And in terms of the product, some of the trainees had never seen the product that is heat-stable carbetocin. So within the training, as we are training the EMONC, we are focusing on emotive, majorly 2 days within the EMONC training period. So they are actually seeing the product. And I can positively say, because I'm also a lecturer, one of the facilities that I went to see the students, which wasn't using heat-stable carbetocin, has been able to order, and they are now utilizing heat-stable carbetocin courtesy of one of the people being in the training. When they went back, they insisted that they needed heat-stable carbetocin so that they can prevent PPH. And then, of course, as Mark, we have also done a lot of efforts in doing lots of webinars within the country. So far, we had done about 33 counties, and we've been requested again to continue with the training so that we do all the 47 counties, and we repeat the counties that are still requesting, because many of them are still requesting. And also we want to collaborate also with CHAC, which is a Catholic, it's a mission-oriented organization, so that we can be able to also give the webinars in private, especially Catholic institutions, as Midwives Association of Kenya, because we've been able to get some funding to do the webinars within the counties, about 20 counties from UNFPA. And also Ferring Pharmaceutical has also supported us, the previous 33 counties. So far, I think the counties are receiving it very well. I wish we can do more, especially the Busia County, which hasn't had EMONC training for long, and their maternal mortality is quite high. I wish we can actually do more classes, because if we are going to get good results, then I think it would be better to have more classes. We are hoping to maybe have other donors support, but then of course, if also this team can support us, it would be fantastic, because we think that's one county that needs a lot of support. So thank you very much.
Thank you, Eunice. It's great to hear all of the progress you've made after so many changes that had to be made and accommodations for the Ministry of Health. It's great to hear. Yes, Hadija, I was definitely going to call on you next. We have still our Ugandan colleagues to hear from, and just a few minutes for each organization. So Hadija, if you'd like to speak up, please go ahead.
Laura, maybe before I speak on behalf of the Midwives Association, I am happy that we have another association of midwives. And for us, just a learning from Uganda is this project has really empowered midwives to speak about issues that are affecting women, especially on giving quality medicines to women. So I don't know whether it is the same in Kenya for Eunice, but for us, our experience here is midwives are even taking on sessions even more than the medical officers. I mean, they are leading sessions and everything is just moving on well from the midwife side.
Yeah, absolutely. Absolutely, Hadija. I think this has given us quite a lot of opportunity and also visibility within the country. So we are able to speak about much more. Like, for example, when we went to the county I've spoken about in Busia, they requested, can you also do something on teenage pregnancy? Which now we are looking for funding to also look for ways of supporting the county in teenage pregnancy. And we are in communication with the FCDO through ICM so that at least we can be able to support, of course, several counties in terms of teenage pregnancy because it's quite a problem within the country. So yes, it has given us a platform and also that discussion, that discussion with the counties. They are feeling midwives are supposed to be the people leading in especially among training and also issues to do with PPH, because when a mother dies from PPH, the buck stops with the midwife. What did the midwife do? So of course, this is a game changer for us as Midwives Association of Kenya. And yes, we've also opened up more branches in the counties we've gone to. We've been able to launch branches, Midwives Association of Kenya, because some of the branches, with some of the counties, we didn't have our branch. So as it's been a symbiotic relationship. So thank you so much for asking, Hadija. Thank you.
I'm not sure if Hadija will be able to stay on. She's indicated that she needs to drop soon, but if Annette from the Midwives Association of Uganda would like to give a quick update, just really quick. We still have a couple more organizations to hear from. Annette, can you hear me? You're on mute.
Hello?
Sorry, the other Annette. Annette from Uganda.
All right, okay, thanks. Yeah.
Laura, I think
I asked Hadija to do the presentation. My network is very unstable. It's dropping on and off, and it's better Hadija does the presentation.
Okay, thank you. Hadija, are you there?
Thank you.
Yes, please. Thank you so much. Colleagues, thank you so much for joining our meeting. My name is Hadija Nakatudam, Midwives Association of Uganda. That is basically a midwifery-led association implementing in the humanitarian facilities in West Nile, and also we have some facilities that are in Nsingiro. So I'm going to be that very quick. We were supposed to implement in 26 facilities, but because there were 11 facilities that were given heat-stable carbetocin, and we got guidance from the donor and also the ministry that we focus on them. So probably after the 11, we shall be able to bring on board the 15. So as a Midwives Association, we are employing what we call the low dose high frequency. At first, we had to bring on board mentors from the various districts that were identified, and then we had a TOT, and then after we gave them all whatever that it takes so that they are able to go back to their facilities and then implement. So out of the 6 sessions so far, we can report that 4 have been completed, and we do hope that by the time 3 days are done by May, we shall be able to update our data, and all the 6 low dose high frequency sessions in the 11. Speaking about capacity building, as just like the other colleagues were saying, the government was very clear on the guidance that you do not have to go and do capacity building on only the NLUM PPH commodities, but doing the whole PPH bundle. and that includes prevention and then the emotive care bundle. So the trainers at the facilities were supposed to spread out in the 6 sessions to make sure that the whole entire prevention and management of PPH by emotive is emphasized. And because at some point, when a PPH happens, it's not only midwives that are supposed to handle, we also know the bit of escalation. So for any opportunity that we have to involve everyone at the on-site facility, it is just a plus for us, and we also include the medical interns. Of course, as I communicated, instead of the 26 facilities, we've been able to implement in the 11. And of course, there were challenges. Why? And I'll speak about them. We've heard from our trainers at the facilities is so far we have not reported any side effect from the use of heat-stable carbetocin. It is very safe. And of course, there is increased uptake of HSC as a primary uterotonic in both SVD and C-section deliveries. And of course, we noticed that there's a reduction in PPH cases, especially the ones that are related to atony. And then, of course, facilities have started reporting stock out of HSC, which is already actually affecting all the grantees in the country. And then important to speak about our challenges. Now, the facilities, especially the ones, all of them are in the humanitarian settings, but we had impending expiry of oxytocin. It was quite competing for you to say that now you are implementing the project and then you have heat-stable carbetocin, but then you have expiring oxytocin. So you see that there was a competition. But then we spoke about rationalization of HSC, and because we didn't want the people to be trained and then they're not using the commodity and yet the commodity is there. So they were able to rationalize
We lost you. We have lost you for some seconds, Khadija.
The ampules or tracking the correct having the guidelines. Then of course we're able. Milka, can you hear me, please?
Now I can hear you, but you were cutting off.
Okay, all right. So I was speaking about the other challenge. We have stock out of TXA. I don't know how our other colleagues in the other countries are doing it, but of course the commitment from the government with support from UNFPA were able to get HSC. But for TXA, in most of our facilities, when you find they're basically like around 3 ampules, and which ampules somehow are bought by the health workers themselves, or some of them are even bought by the mothers. So it's quite very challenging. Though the only the beauty about it is TXA is not really like a routine drug as compared to HSC, but it is a challenge. And then, as I said, we are implementing the low dose high frequency sessions. Now, it becomes very hard to have all the trainees for all the sessions at once because they are on site. Maybe today someone is off, then the other day someone is for maternity leave. So somehow the trainers have been reporting those issues, but we've really tried to work them around. And then, of course, because we are implementing the emotive on the bit of escalation, we are lacking the non-pneumatic and shock garments, but I'm happy that CHAI, our country office, was able to procure some, though some of our facilities also didn't get. And also, when you speak about the escalation bit, about the early detection, we do not have calibrated reps. And so our trainers are forced to still teach about the old practice of using the measuring jars to measure blood, but which is not really objective. but we are still, this also gives us an opportunity as an association to really advocate so that we have more calibrated reps given to the humanitarian facilities that we are implementing. And then now there's been delays in another consignment of heat stable carbetocin, because the first consignment that we got from UNFPA, that was the 20,000 doses, almost was divided up into the 3 grantees. And now we've seen that part of it is used, but even the 40,000 consignment that is supposed to come through, UNFPA has not yet given green light. So it's really, really challenging that we may have to get a delay to start implementation of the 15 facilities because the commodity must be available. So basically that is us from the Midwives Association, and I am here to respond to any questions. And thank you. Over to you, Laura.
Thank you, Hadija. Recognizing that we've used up all of our time, and I apologize to Busoga Health Forum and RCRA that we did not get to you to share your updates. If you would like to send me your updates via email, I'm happy to share them out with the group. I know both of those organizations are wrapping up their activities. And so we're hoping to kind of share out stories from their implementation. And if there is any last minute questions or comments, please go ahead from the group.
Yeah, Aurora, this is Moses. Maybe I can just
Hi, Moses. Thank you.
Yeah, from the Busoga Health Forum. Thank you. I know we shall share our updates. Benjamin will do, but I think for us, ours is just a question which I know even Hadija, where she sits, can make a response. Is on because we have seen increasing referrals of PPH cases from center twos, and yet our government has is clearly removing center twos from doing maternal services, but because of scarcity of services and because people are far in the rural areas, they easily access center twos. So many cases are coming from the lower facilities, which are not targeted facilities by government for MCH related activities, but also for our project. And yet our training is just targeting center threes upwards. So I don't know what our colleagues in Kenya and maybe the experiences from Hadija, what they are doing in the area where they are. But for us, we have that observation, which is coming up. But the other issue of the training, the colleges have contacted us and our members have accepted to give a hand to train the nursing colleges, especially Ginger School of Nursing has officially written to us a letter that they need some basic training around emotive and the PPH management as per the project. Thank you, Laura and members.
Maybe I could just speak to that. Just as the AD has said, I'm Benjamin, also from BHF. One thing that as we prepare to give an update that I don't want to leave behind, we have also seen other facilities because here in Uganda, within the Ministry of Health, we have a big drive to look at maternal and child health issues through local maternity systems. And we have seen, I just read one of the stories where the health worker said, it's a vocabulary big magic, and this was away from the facilities that we have trained. So I'm just seeing this has been an opportunity to see that it is now scaling out. It is a replicative effect. So I know when we look at the gaps that are happening very soon, I know we shall be able to scale up and then see that we reach more midwives. Just like Hadija said, I, as the nurse cases themselves and having a few engagement of the medical officers, even sometimes better than them, that's the good thing and the good success from seeing from this project.
Thank you, Benjamin and Moses. Did anyone have a response to Moses' question about level 2 facilities? I don't know if Khadija heard that. I think we're losing people. I understand we've gone past our time and people need to jump to other meetings, but I really appreciate everybody joining today and sharing their experiences and questions. Really, really great to hear the dialogue between all of our grantees, and we look forward to scheduling another community of practice. Thank you all for joining today, and we will share out notes in the recording for those who were not able to join. So thank you all for your time today.
Thank you. Bye-bye.
Bye. Thank you.
Thank you.
Thank you.
Bye-bye.
Thank you. Thank you.
Thanks
Thank you.
so much.
Bye-bye.
Thanks, Laura.
Thank you.
Thanks, Laura. Bye-bye.
Bye-bye.